Welcome to part 3 of CT angiography oncologic applications. And we were finishing up some of the pancreas work in the last talk. We got up to mucinous cystic neoplasms. MCNs typically are females. Usually it's in the body of the pancreas. The thing is, about 40% of these are malignant, and so they're all kind of treated, or almost all are treated, as if they're pre-malignant or malignant, and so they get resected. Now there's some thought if a lesion is under 2 centimeters, perhaps you can watch it, but most of the time they will be resected. They contain ovarian stroma, and an article I read literally yesterday said those with ovarian stromas are probably less likely to be malignant. In this article by Galuza, which was just published, talking about cystic pancreatic lesions, and again, they talk about the grandmother tumors, which are the serous, the mother tumors being the MCNs. MCNs usually grow in the body or tail of pancreas, and they can reach large sizes. They can cause, but rarely do cause, obstruction of the pancreatic duct. They have septations. When the septations are thickened or there's nodularity present, then the lesions essentially always are malignant, but again, they are going to be invariably resected. You can also confuse at times an MCN with an IPMN, but usually it's not an issue because IPMNs essentially always are connected to the duct and MCNs are not. Here's a classic MCN, body of pancreas, no duct dilatation, nice septations present. But the septations are well seen, particularly on the 3D mapping. In terms of arterial and venous phase imaging, nodularity enhancement may be best seen arterial. The septations may be in more detail on the venous phase imaging. Again, here comparing the routine axial with a cinematic rendering, showing you very nicely the septations with nodularity. And this was a low-grade dysplasia. And here's another low-grade dysplasia. So size alone is not going to help you. Obviously, the larger it gets, the more likely you are to have a high-grade dysplasia, but not necessarily. The more septations you have, the more nodularity. You go from high-grade dysplasia to carcinoma. Again, this one is a low-grade, multiple septations. Most of them are thin. There's a little bit of soft tissue. There's no dilated pancreatic duct. Another one, cystic, but it's much larger. Again, the first guess you would say a serous cystadenoma, not so much an MCN, but this has septations, large, good location, and this was an MCN with high-grade dysplasia. Again, you could see as we do some of the reconstructions, the multiple septations that are present, the compression and narrowing and near occlusion of the patient's splenic vein. Again, in terms of being able to say routinely off the CT alone, if I just see septations, it's a tough call to be how low-grade versus medium versus high-grade dysplasia. That's one of the things we're looking at using cinematic rendering to try to help you there, but also using radiomics and AI with deep learning to help us perhaps be able to make the diagnosis of what's low-grade dysplasia, and maybe you leave it behind, versus high-grade dysplasia. When we talk about cystic pancreatic lesions, one of the things that's often left off, but we do see it frequently and it can be confusing, are cystic neuroendocrine tumors. Most neuroendocrine tumors are hypervascular, usually seen better on arterial and venous phase imaging, but I showed you a few variants of that. You can see these neuroendocrine tumors with certain syndromes like MEN type 1 or neurofibromatosis or von Hippel-Lindau. What's interesting is they look at times almost identical to an IPMN. They're often small, but they have this rim enhancement. Also, they can be seen within the pancreatic duct. Those are the ones that have serotonin positive, and the serotonin causes narrowing of the duct, so you see duct dilatation distally. Here's a good example. When you look at this lesion very quickly, you say, oh, this is an IPMN. I don't see much else, but I don't see a dilated pancreatic duct, which you should see. And then you look more carefully here, you do some of the volume rendering, you really appreciate the rim enhancement, right? You really can see that very nicely. That's not going to be an IPMN. IPMNs do not have peripheral enhancement. Could it be an MCN? I guess theoretically, yes. They can have some enhancement, but the classic ring enhancement is going to be a cystic neuroendocrine tumor. Now that one was small. Here's a larger one, right? You can see thickened wall, some nodularity. It's maybe 5 centimeters. That was a cystic neuroendocrine tumor. So again, cystic lesions with rim calcification, you better be thinking about a neuroendocrine tumor. They can be small or they can be large. And here's just showing you a few more images. Now, what else can we look at? We can look at the kidney. We have spoken in the past about the kidney, the importance of using CT angiography for being able to determine lesion etiology. Remember, with renal cell, 85% are clear cell. Clear cell are hypervascular, papillary, or hypovascular. We could look at neovascularity. At times, the vascular map can help us looking at chromophobes. That can be possible. We also talk about surgical planning, partial nephrectomy. CT angiography is a very good way of creating maps for the surgeon to determine who is and who is not a partial nephrectomy candidate. So that indeed can prove to be very, very helpful. So things we look at: lesion detection, classification, staging, preoperative planning, and monitoring response to therapy. Now, obviously, CT angiography, not only in kidney and adrenal, is good for monitoring response for therapy, but that's true with any of the tumors I've mentioned today or on prior talks. Now, if we look at the kidney first, this was an article by Steve Rowe talking about cinematic rendering, the importance of cinematic rendering, again, for displaying the tumor. CT angiography is a critical part, obviously, of cinematic rendering. And so in this case, arterial phase, larger mass left kidney, but the mass is not very vascular. It's solid. You can see septations better on the cinematic rendering, but it's still a hypovascular mass, and this was a papillary renal cell carcinoma. The average attenuation of a papillary is under 90 Hounsfield units, even on arterial phase. On the other side, clear cells are vascular, typically average 150, 160, can be much higher, but they're typically over 100. Clear cells can have central necrosis. One of the things that can be shown well with CT angiography is both the vascularity and central necrosis. It's been shown that patients with central necrosis tend to do worse with chemotherapy than patients without it. Nice example here of the CTA showing you the patient's two right renal arteries, the dominant renal artery and its encasement as you get to the patient's tumor. You can see the vascularity of the tumor, the central necrosis very nicely shown on the cinematic rendering. And here again, just really nice display of the cinematic rendering. You can see the tumor comes a bit too medial. It's just not going to be a good tumor for partial nephrectomy because here it's involving the patient's renal arteries and really coming central into the patient's renal hilum. And again, here's just a few more renderings. Again, one thing about cinematic rendering, it really can give you very nice images and good detail, but you also can see the variability in the images I can make, which is both good and bad because theoretically you could hide things. And if you don't have experience in doing cinematic rendering, perhaps it can be frustrating. Another case, large right renal tumor, it basically infiltrates the right kidney. Compare the right and the left kidney. The left is normal. When I see an appearance like this, I'm thinking about lymphoma with infiltration and encasement. This ended up being a very, very large infiltrating clear cell renal cell carcinoma. Remember, I said clear cell is hypervascular. This is anything but vascular. Clear cell can be aggressive and look irregular, though usually is better defined. Here it's really infiltrative. I would go with a lymphoma. I could also maybe throw in a transitional cell carcinoma, the way it involves the upper pole, and transitional cells are also relatively hypovascular. But to come up with clear cell would not be what I'd be thinking in this case. You can see the tumor also involves the renal pelvis. There looks like a filling defect, which is in part tumor and in part blood clot in the lower pole calyx. And when you infiltrate the calyces like this, I got to be thinking about transitional. But again, we can tell this is not a partial nephrectomy. The patient will need chemotherapy. Again, I would have considered lymphoma as a possibility. I would not have considered clear cell at the top of my list. And here it is again very nicely showing you the infiltration of the upper pole. On these views, you say lymphoma by infiltration, but again, I just don't like clear cell, which over 90% of the time is going to be hypervascular. And again, here's a few more cinematic rendered images showing you that process of infiltration, which is really just a bit unusual. And here it is on the volume rendered coronal view, nicely showing you the infiltration. Again, TCC would have been up there in the differential diagnosis. But one of the things we've learned with renal masses, we have rules, but tumors often do not follow the rules. So it's just not going to be perfect. Another patient, back pain. What do you do with this case? Well, you can see that there's a large mass. On these images, there's some vascularity. Truthfully, I can't tell you, is this coming from the kidney or from the adrenal. When you look at the coronal, it's very clear it's adrenal pushing on the kidney. You see the peripheral vascularity. The rest of the lesion looks pretty solid. I guess it's large, as in 8 to 10 centimeter range. You would have to think about a primary adrenal cortical carcinoma. Less likely a pheo because it's not vascular, but theoretically it's possible. We've seen a few adenomas that have bled with vasculature present. A metastasis of the patient had melanoma or hepatoma would be possibility. If you look at the lesion with MIP, you see some of the vascularity that's present. And when you go to venous phase imaging, you see lots of puddling. It's a little atypical for what you would expect to see with a hepatoma metastasizing to the adrenal. You can see neovascularity, but not this puddling. It's not the look of a pheo, which is vascular, but this puddling. An adenoma, I can't imagine all of these prominent vessels going through it. Could it be a hemangioma, something like that? I don't know. It's a large mass. What I do know is this lesion is going to come out, and it ended up being an adenoma. It had some bleeding within it, but it was just an adrenal cortical adenoma. So very, very unusual, right? You know, we typically say, oh my goodness, this must be, malignant. This was benign. Size is important with adrenal lesions, but again, you can have large masses, whether it's adrenal adenoma or, like in this case, which is adrenal cyst. And we just published an article with the people in endocrinology talking about large adrenal cysts, that when they get to 10 centimeters, at that point, perhaps they will stop growing and you're able to follow them. But adrenal cysts can be very large, but compared to the prior case, water density, very well defined, very nicely shown there. Large simple adrenal cysts over 10 cm tend to grow more rapidly than smaller cysts. Cysts under 10 cm can remain stable for long periods of time. These results indicate that observation of asymptomatic simple cysts under 10 cm may be appropriate. So you can follow it as it grows, watch it. If it grows really fast, maybe take it out. But once it hits 10 cm, that may be the magic number based on looking at a large series of cases at Hopkins. Another patient, left upper quadrant pain. At first we see what looks like a large spleen. What else is going on? But then you come into a very large mass. Is this a retroperitoneal sarcoma? Is this something coming off the kidney? Something coming off the adrenal? Coming off the tail of pancreas? There it is right here, pushing down on the kidney. So it's not a renal mass. It's a large left upper quadrant mass. The cinematics shows it's cystic and solid with mottled attenuation as well. Very nicely shown here on the cinematic also. You see the stretching of the vessels from the celiac to the SMA, just how the tumor fits in there. And this was a ganglioneuroma. Now, I would have said an ACC, though it wasn't very vascular. Metastasis is almost too big for a met. Some type of crazy angiosarcoma. We've seen a few of those in the adrenal glands. But this was so large. But this was a ganglioneuroma. Ganglioneuromas are uncommon tumors. They're usually relatively hypovascular, but they're usually not going to be this large. I'll finish up just making the point. That case on the left looks like the case on the right. But this is a large mass. CT angiography nicely shows you the neovascularity. Again, in looking at adrenal lesions, when I start seeing this neovascularity, to me it means I'm dealing with a primary adrenal cortical carcinoma, which this was. Or in this case, in a patient with repeated scanning for ulcerative colitis, descending colon, left adrenal mass, solid, necrotic, faint calcifications, not very vascular, but this is very good for adrenal cortical carcinoma, again nicely shown on the cinematic rendering. Or this case with a necrotic tumor, you see some of the vascularity on arterial phase imaging. You can see on the CT angiographic mapping some vascularity, areas of necrosis, displacement of the spleen and the patient's left kidney. And in the cinematic, it really accentuates necrosis. So one of the things I see with CT angiography, particularly with the arterial phase map, is the ability to look at tumor inhomogeneity and look at tumors that become necrotic. That could be a good sign. It could be a good sign after therapy to show maybe the tumor is shrinking or becoming more necrotic, or a presentation showing you that it's a very, very necrotic tumor. We talk about other tumors, primary adrenal lymphoma. We recently wrote an article about that. Usually bilateral, usually very large. It's homogeneous in enhancement. It's adrenal shaped, but it's not very, very vascular. And again, we talk about adrenal lymphoma as part of a multi-organ process. The cases here are part of a primary adrenal lymphoma, where it's the only site of disease. Kind of an interesting case. Now, in contrast, bilateral adrenal masses, you go through the differential of metastasis, bilateral pheos, adenomas, metastasis. Arterial phase, it shows impressively that it's not vascular at all. There's some enhancement bilaterally, but not very vascular. And when you go from arterial to venous, the areas of low density, maybe representing necrosis, are better seen, particularly on the coronal view, on the excretory phase image on your right. But here it is with the cinematic. Again, the cinematic from the CTA angio shows you very nicely on arterial phase the areas of necrosis of the tumor, the adrenal shape of the tumor, and that puts me in the category of primary adrenal lymphoma. Metastases are usually round. Pheos can be bilateral, ACCs can be bilateral, but usually not so large. And again, you got to be thinking about primary adrenal lymphoma, very nicely shown here. And in the coronal view, the fact it kind of maintains the adrenal shape, kind of triangular here, is a really good diagnosis for saying it's primary adrenal lymphoma. And here it's interesting, you can see it on the films, but here as well, there's a difference in the degree of decreased attenuation between the right and left adrenal gland, nicely shown also on the coronal views. This patient has a lung nodule, which is vascular, and you see a vascular mass in the adrenal bed. And again, looking at this sharp vascularity around the periphery of the lesion, the advantage of CTA, this is not going to be a benign lesion. It's not an adenoma, it's not a cyst. I got to be thinking about a tumor maybe with central necrosis. Could it be an ACC? Absolutely yes. Could it be lymphoma? Absolutely probably not, because lymphomas are not that vascular. The lesion, even on late phase, washes out, but it's still thickened wall nodularity and central necrosis, and that was a pheochromocytoma. Again, with pheos, 70% of the pheos we picked up are incidental findings. Pheos can be very vascular, which also explains the patient's lung findings. One of the things with pheos is you can have an enhancing rim, and we've seen some cases of that as well. So now let's look at the last things we'll talk about, small bowel and colon, and a little bit about complications. But let's do this. Let's take a short break and come back in a couple minutes and finish this talk. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.